Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on the peritoneum. This is the third part of the series of presentation. In this part actually includes the peritoneal distribution in the lower abdomen, the various folds found here, and the various spaces that is trapped in this peritoneal cavity, and every stage there will be clinical correlation. This is the first one, right side. This is the coronal section and this is the median section to show the abdominal cavity. You see this one is the diaphragm on this section, and this is the diaphragm on this section. So above this is the thoracic cavity, and below, if we go, we'll find this is the pubic symphysis, and this one is the sacrum in median section. So this is the upper part of the pubic symphysis, and this one is the sacral promontory. If we connect, this is sacrum, and if we connect it, this is the line connecting here, and here you can see this is the circular line at that level. So this is the inlet of the pelvis. So here you can see this is the line of inlet that separates the upper part. This is the abdominal cavity proper, and below this is the pelvic cavity. So the abdominal cavity is divided into abdomen proper and pelvic cavity by inlet. You can see these two cavities are all the organs are removed except those on the posterior wall. So these are covered by the peritoneum anteriorly. Some are covered also by the lateral to side wall also. So these are the retroperitoneal organ. Already we have discussed in some other parts. So let us find the names. This is the kidney. This is suprarenal gland, and they are on either side. This is the duodenum. You can see this is the curved duodenum. This one is the pancreas starting here to the spleen. This one is the ascending colon. This is descending colon. These are the vessels, means it is abdominal aorta, and by the side this is vena cava. So all these organs are on the posterior wall and are covered by peritoneum. The lower abdominal organs, already in other parts we have discussed the organs of the upper abdominal. You can see these are the organs within abdominal cavity, and they are connected to the posterior wall by folds of peritoneum. So intraperitoneal structures all are covered by the visceral peritoneum, and the folds connects them, and this is the attachment margin to the posterior wall. Now the outer part, the wall is covered by the parietal peritoneum, and you can see this is reflected over the organs and running on the posterior wall, and this is attachment line of the mesentery, and these are the parietal peritoneum. This is the greater omentum that hangs in front of all these organs. You can see this is the ascending colon, this is the descending colon, and peritoneum covers the anterior side and side wall of this organ. The small intestine, the proximal most part, that is about 1 inch proximal part of the duodenum is intraperitoneal. Rest of the part is retroperitoneal. You can see this is the duodenum, and it's a totally retroperitoneal structure. but from the beginning of the jejunum to the end of the ileum are intraperitoneum. This is the small intestine, most of the part except duodenum. The duodenum is fixed to the posterior wall. So these are intraperitoneal. Within the peritoneum, this is covered by the visceral peritoneum, and from the border to the root, it is connected by the mesentery. So this is known as the mesentery. This is the photograph of large intestine. The begins at the cecum, and the cecum is intraperitoneum, so it is supposed to have a mesentery, but this is so small that it cannot be identified as a fold. To this is attached is the vermiform appendix. This is having clean cut mesentery. You can see a triangular become narrow at the tip and broader close to the base, and is attached to the mesentery of the terminal part of ileum, and so it is intraperitoneal and has mesentery. This is known as mesoappendix. Now you can see this is the ascending colon, and on the other side this is the descending colon. These two parts are retroperitoneal, behind the peritoneum. So this anterior wall and side walls are covered by the peritoneum and fixed to the posterior wall. This is the transverse colon, and this one is the sigmoid colon. Both are intraperitoneal, has mesentery. You can see this is the mesentery of the transverse colon, known as transverse mesocolon, and this is the mesentery of sigmoid colon, known as sigmoid mesocolon. This sigmoid colon continues as rectum and anal canal. This become a pelvic structure, will be discussed separately. Now the mesentery. This is the small intestine. So the peritoneal fold of this is known as mesentery. So this small intestine means jejunum and ileum connected to the posterior wall by this fold, and you can see this fold is attached to the posterior wall by an oblique line. This is the root of the mesentery. By this, the mesentery remain attached to the posterior wall. This is cut off, and you can see the cut margin of the mesentery, and this is the root. To at this point, this was attached. So it's an oblique line extending from here to here. This attachment is about 15 centimeter long in case of adult male, and you can see this is running to the border of the small intestine. It's about 20 centimeter long in case of adult male. Now this root is smaller, it's about only 15 centimeter, but the small intestine is a very long structure. So intestinal border is very long, it's about approximately 5 meter long. So there are many folds. You can see if we cut the intestine off, and we can see how many folds are there. So this border is about 5 meter long, and this border is only 15 centimeter long. This starts from the above to the down. This starting point is about the left of the uh, lumbar 2 vertebral body. Here it is the lumbar 2 vertebra. This is the end of the duodenum and beginning of the jejunum. Here is the starting point, and here lies the lumbar vertebra 2 body. It runs downwards and to the right up to the sacroiliac joint of the right side. So this is the right sacroiliac joint. So the root extends obliquely from the right side of the lumbar 2 vertebral body to the right upper part of the right sacroiliac joint. Let us see root of the mesentery causes which structure. So this is the beginning point, and this is the line of attachment of the mesentery root. This one is first part of the duodenum, second part of the duodenum, third part. So third part of the duodenum is crossed first, and here this is the mesenteric vessels that gets entry into the mesentery. This is crossing the abdominal aorta. Then this is the inferior vena cava. It goes down. Here there is ureter on the right side. So I have to give another photograph. You see, look at this. This is the duodenum, crossing duodenum, getting entry of the supramesenteric vessels. Then it crosses downward aorta and vena cava. Crossing vena cava, it gets the ureter. Then it goes downwards and to the right and crosses the psoas major muscle. You can see the psoas major muscle here also. This is the right ureter, and this is the right psoas major muscle. So this mesentery of the small intestine, which is known as the mesentery, is composed of two layers of the peritoneum and makes a fold. So within these two layers, there is large amount of fat. The jejunum and duodenum makes its margin, and the peritoneum covers it. The superior mesenteric vessels means artery and a vein gets here inside the peritoneum and gives many branches to the jejunum and the ileum. This one as the entry point of the superior mesenteric vessels. So giving the jejunal and ileal branch. Similarly, the vein is returning back to the vein. So jejunal and ileal tributary of the superior mesenteric veins remains here. The nerve plexus follow the artery and lymphatic vessels and also some regional lymph nodes. The mesentery group of lymph nodes remains within the peritoneum. Fat is the large contribution or content of this area. Mesoappendix. This is the vermiform appendix having a triangular fold, you can see, and it is cecum. This is the ileum. Ileum has mesentery. That side is the posterior surface, a deeper surface of the mesentery of the ileum, and this is the terminal part of the ileum. So this mesoappendix goes back and remain attached to the posterior part of the ileal mesentery, terminal part of the ileum, this one. So this can be easily identified and can be traced for its attachment. This contains the appendicular vessels. This one is the appendicular vessel that runs along the margin up to the tip and gives several branches towards the appendix. So this is an interest of the surgeons because they have to ligate. If they ligate away, they leave some branches to the base, and when they cut it, there will be severe bleeding. So they should be aware of the position of the vessels and branches. Beside that, this also contains the nerves, lymphatics, and a few lymph nodes within this mesentery is also present, mesoappendix. Transverse colon, this is the transverse colon and has mesentery known as transverse mesocolon. You can see this is the transverse mesocolon. Here this is the transverse colon and this one is the transverse mesocolon. Keeping the transverse colon attached to the posterior wall of the abdomen transversely. You can see this is attached to this is the duodenum, this is the pancreas and going spleen. This is the hilum of the spleen. So transverse mesocolon transversely and obliquely goes to the left from the right side, and we can see this is the color changed here to show you. Let me show again. This is the color change is showing the root of the transverse mesocolon, and this is crossing the duodenum. This is the second part of the duodenum. Then we'll get the pancreas longitudinally crossing the pancreas, and this is the kidney, left kidney. Finally it crosses, and close to this is the colic flexor. So going up to the left colic flexor, also known as splenic flexor, the transverse close bends to become the descending colon. So up to this level, this is transversely going up to the level of the splenic flexor, close to the spleen. You can see this is the transverse mesocolon. Transverse colon is turned, so you can see the transverse mesocolon. And you go below, the descending colon is retroperitoneal. Then sigmoid mesocolon starts from the wall of the sigmoid colon, and sigmoid colon is intraperitoneal. You can see this is the sigmoid colon going to the pelvic cavity. So this is having mesentery, and mesentery is V-shaped, and root is forming a V-shaped attachment. This is the apex of that V, this is the apex of that V. So root has V-shaped attachment, and the apex of the V is attached here. This is the abdominal aorta, vena cava. This is common iliac artery and vein. So common iliac artery bifurcates into external internal here at this point, and formation of the common iliac vein, left common iliac vein is here. So just in front of that, the tip of the V is attached. Apex of the V is overlies this division and formation of vein and division of the artery. Here, deep to this lies the sacroiliac joint. So, one landmark, this is in front of the sacroiliac joint, also overlies the division of the common iliac artery and also formation of left common iliac vein. These are the two limbs of the V-shaped root. So this is the left limb, this is the right limb. So the left limb is running over the left psoas major. You can see this is the psoas major, and goes to the external iliac vessel. So over the external iliac vessels is running almost parallel, and psoas major muscle. On the opposite side, the right limb descends downwards obliquely and pass up to the level of the third sacral vertebral body. In front of the middle of the third sacral vertebral body is the end point. So the V starts from the midline, close to the midline, in front of the sacral body, ascends upwards and the level of the sacroiliac joints. Then it runs to the left side, parallel to the external iliac artery. So this is the attachment of the sigmoid mesocolon. Now we have discussed the folds of the abdomen proper, lower part, because in other presentation we have discussed the upper part distributions. So let us start the peritoneal cavity. So this is the cavity between parietal and visceral layer that you understand here. It contains a small amount of fluid that is known as peritoneal fluid. Here this is stained green. So this cavity is a very large cavity, already we have discussed, is the greater sac, and a small part trapped behind the stomach is known as lesser sac or omental bursa. They are connected by a small opening is known as epiploic foramen. This lesser sac is limited to the upper abdomen cavity we have discussed in part 2 in detail. So this is the connection, epiploic foramen, who lies just above the duodenum, below the carotid lobe of the liver, and posterior to the free margin and in front of the vena cava. This is the lesser sac position. Rest of the part is the greater sac position. Peritoneal cavity has several spaces, divided into several spaces for clinical purpose. All the spaces are continuous, but because of the variation of the dependency, if abnormal fluid collects in the peritoneal cavity, that goes to the different spaces. That's why these spaces are clinically important. Now it divided into the two parts. You can see this is the transverse colon. So clinician consider this is the line of division. So this peritoneal cavity above the transverse colon up to the diaphragm and one part, and below the transverse colon is continuous in the cavity of the pelvis is the another segment. So this is the line of demarcation. This is the transverse colon position. If we draw the line, the above part is known as supracolic or supramesocolic, because mesentery of the transverse colon and colon together making this line of division. That's why known as supramesocolic, but commonly it is known as supracolic. And so the part below is known as infracolic or inframesocolic part. This is the line of demarcation, means transverse colon and its mesentery is the line of demarcation. Let us see the further division. If we draw a midline, and the right side of the supracolic region is one part, left side of the supracolic region is the another part. So above this lower limit of the lever is called the right subphrenic space, means below the diaphragm space, and below lever space is known as right subhepatic space. So you got the idea. The total transverse colon and mesocolon divides it into supramesocolic or supracolic area. Now if you draw a midline, this is right side and this one is the right. So right supracolic, left supracolic. So right supracolic again divided by the presence of the lever. So space from the diaphragm to lever is right subphrenic, below phrenic, subphrenic area, and below the lever it is known as right subhepatic space, right subhepatic space. So it goes up to the transverse colon. So these are the spaces of the peritoneal cavity above the transverse colon. So this is the position of the transverse colon. You can see transverse mesocolon cut margin is shown. So the part below the diaphragm above the transverse colon and mesocolon is the supracolic area. That you can see better here. The clinical description for the clinician, these are called some spaces. So subphrenic space, subhepatic space, these are called spaces. So if I draw a line, we can see this is total supracolic region. Midline will divide right side and left side. Right side, this is the this is total right supracolic area, and this is a left supracolic area. So let us summarize: right supracolic space, left supracolic space. Let us say space. Now right supracolic space, right subphrenic means diaphragm এর নিচের অংশ, sorry, just below the diaphragm. Then right subhepatic just below the liver, and you see behind the stomach another space is there, that is the lesser sac. So in the right supracolic area we will get three spaces. One is tapped behind the stomach is lesser sac, and in front of the stomach is greater sac. That greater sac has right subphrenic just below the diaphragm and above the liver, and below the liver up to the transverse mesocolon and transverse colon is right subhepatic space. So right side is clear. Now left side. So let us see the in photograph. This is the liver. This is the diaphragm. So this one is the transverse colon. So this space is right subphrenic space. You can understand. This one is the right subhepatic up to the transverse colon. Now it is section is parasagittal region towards the right side. So let us move a bit medially. So on the right side there is duodenum. We are not getting stomach. So let us move towards the left side. Still there is duodenum. So above duodenum, this is the epiploic foramen now visible. If we go further to the left, we will find this is stomach. So this is lesser sac, and this is subphrenic area. This is subhepatic area, and the lesser sac is visible. So all these are on the right side. Go up to the midline, then you will get the left side. Left side again, it is divided into the left subphrenic space and left perihepatic space. This is not known as the subhepatic. This is perihepatic because it is surrounding some part of the liver. Now you can see another diagram that shows this is the on the right side subphrenic space continuous with the subhepatic space. This is left subphrenic continuous with the perihepatic space. If you go below, then cavities are a bit different. So above supracolic area, you see this is continuous. This is subhepatic region, also known as hepatorenal space. Now infracolic area, below this attachment, you can see on the posterior wall, this root of the mesentery obliquely divides this area into smaller right part, triangular area, and a larger left part. So this transverse colon and its mesentery separates it from the supracolic to infracolic. The infracolic area, this is below the transverse process and transverse mesocolon. This root of the mesentery divides the infracolic area into obliquely two parts. This is the root of the mesentery, so it divides into this left part. This is left infracolic space. Naturally, on the right side, this is stained bluish. This is the right infracolic space. This is the descending colon. So descending colon has a gutter, drain on its lateral side. This is left paracolic gutter. So similar gutter is there on the right side. This is the right paracolic gutter. So total infracolic area we can divide from the left side, left paracolic gutter, left infracolic space, right infracolic space, and right paracolic gutter. Sometimes the other side, this is also considered as the paracolic gutter, and this is another drain-like area is also considered as gutter, but this is the continuous with the infracolic space. You can see this is the left infracolic space, and this is continuous with the pelvic cavity through a larger opening, larger area uh, here with the pelvic cavity. But on the right side, this area is a bit triangular trapped area that is obstructed by the root of the mesentery. But this is continuous with the paracolic gutter of right side. So right paracolic gutter is continuous with the pelvic cavity. Similarly, the left one is also connected to the pelvic cavity. So any fluid accumulates air can go into the pelvic cavity. The left infracolic segment directly goes into the pelvic cavity. this right paracolic girder can go, but this area is connected to the pelvic cavity through this girder. So this and these two are having free communication with the pelvic cavity, but only this one always connected through this. So any fluid connected here, and if you find in the pelvic cavity, let us see the paracolic garter formation. We can understand the peritoneum as shown by the white line. From the posterior wall, the parietal layer moves, covers the side of the colons. This is the ascending colon and descending colon. So side is covered, then front is covered, then side is covered, reflected over the posterior wall. So this is the garter, right paracolic garter is formed. The on its left border there is another garter, but that is continuous with the infracolic areas. You go to the other side, you can see the parietal peritoneum covering the side of the descending colon, then front and then side, and covers the posterior wall, parietal peritoneum. So this is the garter formed on the left side. This is left paracolic garter. You can see this is the shaded area is showing. This is the right infracolic area is continuous over this to the garter, and then through the garter it can communicates with the pelvic cavity. But this is not directly, but this area is directly connected with the pelvic cavity. Garter is also directly connected to the pelvic cavity of either side. Recesses are the small spaces. It's a pouch-like, pocket-like, depressed areas, but it's formed because of the peritoneum folded around the organs. Let me give some important examples. You see, this is the duodenum, and duodenum has two pockets here. This is duodenal recess. This one is the cecum, and behind the cecum there is one trapped area. This is recess in the cecal region. So these are the potential spaces where fluid can remain collected. And if there is polluted fluids in the peritoneal cavity because of the disease, that surgeons should take care of these areas, because the bad fluid may remain in these pockets. That should be clear. That's why these recesses are clinically significant. The site of internal hernia of the organs are also possible. This is the jejunum that can be trapped within this cavity, and this is known as internal hernia, because anything protruded through the weakness of the wall is known as a hernia. So internal hernia also can occur through these spaces. And peritoneal cavity contains fluid that is a small amount, but that can lubricate the surface of the organs and abdominal wall, avoiding the friction during the movement. The viscera are moving always because of the peristalsis. So this frictional injury is prevented by lubrication of the fluid. Peritoneal folds, you can see, the suspends the various organs into the cavity and serves as a means of or convey the blood vessels through this to the organ. So this is the conduit of blood vessels, lymphatic vessels, and the nerves to the organ from the wall, and from the organ to the wall. And as we have said, this peristalsis movement, wise degree of peristalsis movement is permitted by these folds of greater momentum should be explained different for the function, because this is having some clinical important function. Greater momentum, you can see this is hanging from the greater curvature of the stomach in front of all organs. If we separate the wall or open the wall, we will first find the greater momentum. You see, this is the greater momentum that covers all the organ, the anterior surface of all organs, and just separates the organs from the anterior abdominal wall. This prevents the adhesion of the uh, visceral peritoneum. You see, this friction can cause some injury, and there may be adhesion of this organ to that uh, injured part, but this is prevented by the greater momentum always. This greater momentum hangs below. It's a has some degree of mobility. So peritoneal, within the peritoneal cavity, the viscera can easily move, and this greater momentum covers this organ and prevents the frictional injury to this organ and adhesion to the inflamed part of any organs. Like if appendix is uh, inflamed, the greater momentum around that can move and surround that inflamed part of the appendix and protect other organs to be affected. In the same way, if a small part of the intestine, a small intestine is affected, it surrounds that area and tries to separate that inflamed, means diseased part from rest of the part of the intestine. And that's why it is known as abdominal policeman. It tries to localize the problem and tries to protect other organs, and so that the body can continue its function normally. So let us consider the peritoneum of the pelvic cavity. Already we know that the pelvic cavity contains the rectum, that is continuation of the sigmoid colon, and the urinary bladder in case of male, and uterus goes in between these two structures. So in male and female, there is variation of the organs in the pelvic cavity. In female, the uterus is separating the urinary bladder from the rectum. So this is one extra organ in the pelvic cavity. So peritoneal distribution is different. This is the uterus, you can see. So in between rectum and urinary bladder, this is present. But in male, this prostate, that is the organ, uh, internal sex organ, this is remaining below the bladder, and this seminal vesicle is tightly adherent to the posterior wall of the urinary bladder. This is not as projecting like uterus. So this is the peritoneal covering is different in either sex. And see, this is the seminal vesicle, and this one is the prostate. It is labeled here. So in the uh, male, the parietal peritoneum goes from the posterior wall down. You can see this is the rectum. It is seen from the anterior aspect. So peritoneum is covering its, and this is sigmoid colon and becoming rectum. So in the pelvic cavity, anterior surface of the rectum is covered, and on either side, the lateral side is also covered. So it is right and left pararectal fossa are produced. So this anterior surface peritoneum, and on either side you can see the fossa on the right and left side of the rectum. These are known as pararectal fossa. So peritoneum is making this fossa. This is pararectal fossa. This is parietal peritoneum. Side wall of the pelvic cavity, pelvis is covered, and if you see from the above, this is the sigmoid colon is continuing as the rectum, the rectal anterior wall and side wall is also covered, and two fossa are produced. So from the rectum, It is going to the urinary bladder in case of male. Now you can see this is the rectum from the side. Already we have seen this is in the last slide. This is the rectum. From the rectum you can see this peritoneum is going to the bladder. So how it is going? This is the rectum is in the upper third is covered by peritoneum on anterior aspects and side, but in the middle third it only the anterior surface is covered, and from anterior surface it is going over. This is the seminal vesicle. So the peritoneum on the posterior wall is going down, covering the dust. It is the seminal vesicle, tip of the seminal vesicle, this above here, it is covered by the peritoneum and going to the bladder. This is the upper pole of the seminal vesicle is covered by the peritoneum, and then it is going to the, it is the base of the bladder. So upper part of the base of the bladder is covered by the peritoneum, and then it is going to the roof over the superior surface of the bladder. Is after covering the superior surface, from the superior surface it is going to the abdominal. There is no pocket formation between bladder and anterior abdominal wall, so it is directly going to the anterior wall of the abdomen. Posterior aspects is covered by the peritoneum and becoming parietal peritoneum. So in the pelvic cavity, this is just covering the pelvic organ upper surfaces in case of male. And see, this is the peritoneum in the midline going to, this is the bladder, and you can see the rectum forming one pocket here. This is peritoneum is making one pocket between the urinary bladder and the rectum. This is the pocket. So pocket is known as pouch. So one pouch is present in case of male. This is known as rectovesical pouch. Between bladder and abdominal wall there is no pocket formation. So in the pelvic cavity we can see a pocket between bladder and the rectum. That is clinically important because this is the dependent part most. So if any fluid collects, this will go to this pouch, and this pouch can be filled through the rectum. You can see this is, if you place the finger you can feel this pouch. If fluid collects there will be balloon like swelling here. Another figure, you can see the pouch very nicely behind the bladder and stained bluish. This is the, let me do it again. Stain will be, I mean, this is the pocket between rectum and the bladder. So this is known as rectovesical pouch. So in male, the rectovesical pouch is the most dependent part of the peritoneal cavity. But in case of anterior abdominal, this is the, from the roof it is going to the anterior abdominal wall, so there is no pocket formation. If bladder is full, this will pull the peritoneum up, so bladder will come in direct contact with the anterior abdominal wall. In case of female, you see this is the uterus is standing between. So from the rectum, in the same way, the peritoneum from the mid part of the rectum will go to the uterus, and on the way this will cover the fornix of the vagina. This is the posterior fornix of the vagina, this anterior fornix. So posterior fornix is covered by the peritoneum, then it will go to the cervix of the uterus and then body. So the peritoneal foldings will be different. This black line is showing the reflections. So it is going from the anterior surface of the rectum, reflected onto the posterior fornix, then it will go to the uterus, cervix of the uterus. This one is the posterior fornix of the vagina, and this is the cervix, then the body and fundus. All will be covered, and this fold will go to the anterior surface, cover the body, then body and cervix junction. From there peritoneum goes to the bladder. Now you can see there is one pouch behind the uterus, one pouch between uterus and the bladder. So this is the way it covers the whole uterus and going to the bladder. This is from the junction of the body and the cervix from the anterior part. So you can see the pouch formation. This is the rectum is going to the posterior fornix of the vagina, then going to the cervix of the uterus body. So in here one pouch is formed, another pouch is formed in the anterior part. So this one is the recto-uterine pouch, and this is uterovesical bladder vesic. So uterovesical pouch. So in front and behind there are two pouches formed by the peritoneal folds. You can see this is the uterus and this is the bladder. So posterior part, this one from the rectum, it is going to the posterior fornix, over the posterior fornix, then cervix of the uterus, body of the uterus, fundus of the uterus, then forming another pouch. And on either side, you see the fold extends from the lateral part of the uterus to the lateral wall. This is broad ligament. So this is the peritoneal fold that connects the uterus to the lateral side of the goes lateral part of the uterus to the pelvic wall. This is fold. So two layer peritoneal folds that connect the uterus on either side. So there are two broad ligaments attached to the lateral margin of the uterus and connect it the uterus with the lateral pelvic wall. You can see this is the uterus and peritoneal fold connecting it to the lateral wall. This is the broad ligament. You can see this is the uterus. From there peritoneal fold is going and the upper limit is formed by the uterine tube. You see this is the uterine tube that is forming the upper limit of the fold. This one is the uterus. You can see this is broad ligament attaching it to the lateral wall. This is the ovary. This one is the ovary. You can see the ovary is not within the broad ligament. This is separated. This is anterior, so it is separated posteriorly. And ovary has one peritoneal fold. So ovary is intraperitoneal and this fold connect it with the broad ligament. You can see this is the ovary and ovary has mesentery. So the ovary, meso-ovarian, is known as the mesentery of the ovary and that connects it with the broad ligament. So part of the broad ligament that is lying between the uterine tube and the attachment of the meso-ovarian is known as mesosalpinx. So it's a part of the broad ligament, but it is mesentery of the salpinx, means uterine tube. So this broad ligament, superior broad ligament, you see, is containing the uterine tube at its upper limit. This is the uterine tube and it is in the upper border. And round ligament of the uterus run from the corner. This is the is going. This one is the round ligament of the uterus. This is the ligament of the ovary is connecting it with the uterus. And many blood vessel branches of the blood vessels, uterine artery, ovarian artery, are there within the broad ligament. Lymphatics, the nerves following the blood vessels are also present in the broad ligament, and one content we should remember is the fat that is present within the broad ligament. Thank you very much for remaining with this presentation.